Hi guys, welcome to the Pccn review. Welcome, I'm glad you're here. This can either be 4 West, 5 Central, any of you guys who are sitting for the exam or thinking about sitting for the exam. So first we're going to go over some just basic, what's on the test. And then we're going to get into some practice questions. What you will see is the questions, they'll stay up for 40 seconds and then they'll go to the answer slide and I will explain the rationale to you. So let's get to it. The Pccn exam is a 2.5-hour test. It consists of 125 multiple choice questions. There's a total of 125 questions, but only 100 are actually scored. 25 of these are used to gather statistical data. This basically means that you are a guinea pig. They are testing these questions out on you to see if they should use these on further examinations. When I sat for my certification exam, they asked a question about what kind of teaching would I do with NICU patients or parents. And I'm thinking in the back of my head, I would not do any teaching with any baby parents whatsoever. I want nothing to do with taking care of babies, in the hospital setting at least. But I'm pretty sure that that was one of those statistical data questions. You won't know necessarily which ones are those 25 questions. So, just treat every question like it's the real deal. So what percentage is what on the test? Well, I can tell you that you probably need to focus on cardiovascular, as it makes up a third of the test, 33%. Professional caring and ethical practice is another huge hunk, it's 20%. Pulmonary is 14%, and then endocrine, hematology, GI, and renal, they're all lumped together for 18%. Neurology, multi-system, and behavioral are 15%. I'm going to focus a lot of these PowerPoints and stuff on the cardiovascular part, especially questions that I think may be new information to you, some of it. Some of it will just be practice, but a lot of these PowerPoints that I'm going to put out will be cardiovascular in nature because of the huge portion of the test that it includes. So what exactly can you find on the professional caring and ethical practice portion of this test? Things like advocacy, caring practices, collaboration, systems thinking, response to diversity, clinical inquiry, and facilitation of learning. You will find that they talk about the synergy model a lot, and what that refers to is that needs and characteristics of patients and families influence the drive of the nurse. So, they synergize one another. So I'm going to go over just a couple of helpful hints that one of the books suggested. Sometimes your answers are in the questions. You really need to identify and look at the questions. What exactly is this question asking? There's usually 3 parts to each question. There's an introductory statement, a stem, which is the actual question, options that you could choose the correct answer from. As we continue on, I will make sure that I kind of point that out, kind of help you look at the questions and, potentially be able to discern what is the correct answer. So as nurses, we are always looking for the therapeutic response. So if you have a question kind of asking about feelings, thoughts, that kind of fluffy stuff, make sure you acknowledge and validate the patient's feelings. Always validate their feelings before you present them any information. However, if you're faced with a scenario where you can validate the feelings or intubate them because they need it, it's a medical emergency, the medical emergency will always take priority. So again, some more helpful hints. ABCs are always first, or now we talk about CABs, but airway, breathing, and circulation is always the most important thing. It's always the first priority. Your next priority, kind of going along the Maslow hierarchy of needs, is going to be safety. Is safety an issue in this question? If not, then you don't have to worry about it, but it is the next in line priority. Have their psychological needs been met? So it's airway, breathing, circulation, priority, psychological needs. Assessment always comes before diagnosis and treatment. Of course, you have to properly look at the patient before you can intervene. And learning only takes place if you have a motivated learner. If your person is emotionally upset and those psychological needs have not been met, then they're not going to be a motivated learner and they won't be ready for education. So what if you don't have a clue? You're looking at it and you're like, I don't know. I have no idea. Well, what you can do is kind of look at it. If you look at something and it says hyperkalemia causes wrinkles. Okay, that doesn't sound right to me. I'm pretty sure, 99.8% sure that that's incorrect. You can eliminate that choice. Usually kind of look for the most general, all-encompassing option. And as we go along with these questions, hopefully I'll be able to point that out. If two answers are essentially the same thing, then neither are correct, usually. Look for the longest option. I'm sure you've heard that before. It's usually the correct answer. And watch for grammatical inconsistencies and between the stem and options. So, your A, B, C, D and the stem. So it's the night before the exam or even the day of. The most important thing for you to do is not to stress. We'll work together where we can get you to pass this exam. It doesn't matter if you've never seen a ventilator and you have a bunch of ventilator questions. That's also an area I'm going to work on, focusing on ventilators, because I know you guys have not been exposed that much to it, or even if at all. Don't waste your time on questions you have no clue about. Take that systematic approach. I know absolutely B is not right. I know C is not right, or something like, B is absolutely wrong and A and C are just not even, are the same thing, So the answer to A is 1 and the answer to C is 1-ish. So you could eliminate that choice as well. But make sure you answer every question. A guess is better than nothing at all. Because, hey, what if you guess right? You get that point. Don't cram. You don't need any more pressure. You will have this, okay? No problems. Make sure you get a good night's sleep. Eat a good breakfast, probably a light breakfast, not a bunch of carbs, because then you'll be hungry in the middle of the test. Or let's say you're taking it early evening, eat a light lunch, something that is going to sustain you through the exam. Bring earplugs, especially if noise distracts you. The testing site, if you go to the H&R block like I did, can be a little bit noisy. And just take a slow, deep breath. Don't go in there all anxious or anything like that. Just be calm. You will not lose your job because you did not pass this, okay? But the most important thing is you will pass this. Look at yourself every day in the mirror and say, I got this, because you do. Alright, so let's get to some practice questions. I probably should have said this on the first slide, but if you don't need to hear the rationale, or it's something that you're well versed in and you're bored, and I'm sure you probably have already fast forwarded through this, feel free to fast forward through it. I don't know what you're doing, so it's not going to offend me any. But I would like your feedback. If you found this helpful, please let me know. If there's a topic that you would like to kind of look in depth at, please let me know. I will be more than glad to help you in your endeavors any way that I can. So this question is asking about pulse pressure. Pulse pressure is the difference between your systolic pressure and diastolic pressure. In this case, the blood pressure was 120 over 85. So 120 minus 85 is a difference of 35. If your patient has a narrow pulse pressure, this could indicate systemic compensatory vasoconstriction. Say that 5 times fast. If you have a higher pulse pressure, it can be a strong predictor of heart problems, especially with your older patients. Generally, if you have a pulse pressure greater than 40, it's abnormal. Normal pulse pressure is considered 30 to 40. If you have a pulse pressure less than 40, it means you have poor heart function. A higher pulse pressure can mean that your heart valves are leaky. The most important cause of elevated pulse pressure is stiffness in your aorta. The stiffness can be due to high blood pressure. It can be due to fatty deposits on the walls of the arteries. The greater your pulse pressure, the more stiffer the aorta is. Yes, there really will be questions like this on the exam. Some questions, like this one, will seem pretty straightforward to you, and you're like, it's got to be a trick. Don't try and make it a trick, okay? The only thing they're asking in this question is, what's a normal ejection fraction? Well, the ejection fraction should be over 50%. Ejection fraction is the amount of blood ejected from the left ventricle compared to the total amount available. So if you look at this question, they talk about ST segment depression, and they also talk about substernal chest pain. So ST segment depression, it usually indicates myocardial ischemia. The patient also, like I said, had substernal chest pain, which is another finding that can be seen with the ischemia as well as other things. But the ST depression and the chest pain, so stems there, two of them, would clue you into ischemia. If it was an MI, you would not see depression in the ST, you would see elevation in the ST segment. In tamponade, you might see the same ST segments as in pericarditis, where there is kind of a universal ST elevation. There are multiple upon multiple ST segment elevations. 2, 3 leads V3 through V5, and also electrical alternans, which simply put is there's a beat-to-beat alteration in the QRS appearance. Or you may even see some low voltage QRS complexes with tamponade. So I'm going to do a little brief overview of ischemia, injury, and infarction and what you would maybe find with those things. So in your ischemia, like we just talked about, you can see ST depression and T wave inversion. In injury, you might see ST elevation, and in infarction, you're going to see ST elevation. If the patient has a Q wave, this is indicative of a previous heart attack. So myocardial ischemia, we know it causes ST segment depression, but what exactly is it? Well, it's present the moment that there is a decrease of complete absence of blood supply to the myocardial tissue. It can be either mild or moderate anoxia, and it can be tolerated for a short period of time without greatly affecting function. The important thing to remember with ischemia is it can be reversible. What do we have to do to fix it, though? You have to get adequate blood flow, you have to reoxygenate, and so the cells can recover. So the important thing with myocardial ischemia is, to get that blood flow open back up and get the patient reoxygenated, which probably means a wonderful trip to the cath lab. This is a picture of the zone of ischemia. So the zone of ischemia is the outermost area of the heart muscle that's damaged. So this is minimal damage at this point. ST depression, like we talked about in the last two slides, it can be seen in other conditions. It can be seen in left ventricular hypertrophy, right ventricular hypertrophy, ischemia, angina, hypokalemia, hypomagnesium, WPW. Critical anemia can be seen in some bundle branch blocks. And so the choice D was about a tamponade. You will not see ST segment depression in tamponade. Okay, so let's talk about the next step up. So the ischemia persists, it's severe or prolonged. The anoxic cardiac cells sustain damage and stop functioning normally. So, they've received an injury. They're unable to contract or generate or conduct electrical impulses properly or like they normally would. Damaged cells are still reversible, though. Injured cells are viable, and it's still salvageable for some time. Cells may return to normal or near normal after the return of adequate blood flow or reoxygenation, which means, probably a trip to the cath lab. It does at St. Mary's, but in other facilities where they don't have a cath lab, like critical access facilities, it would mean thrombolytics or something that they can do to open up the vessel. So here's a picture of the zone of myocardial injury, or the zone of injury. In the earlier picture we saw in that white circle was the zone of ischemia. Now we're getting deeper into the muscle tissue and we're getting into injury. Causes no blood flow. I think that's a little obvious, but the injured area remains electrically positive. So injury causes ST segment elevation. So you have ischemia, the first level is depression, injury, elevation, infarction, elevation. So a key difference between infarction, injury, and ischemia is that at this point it's irreversible, it's death. Just like stroke is for the head, heart attack is for the heart. An ischemic stroke rather. But so severe myocardial ischemia continues because of the continued lack of oxygen, lack of blood. The cells will sustain irreversible injury and die. Necrosis is present. So after occlusion of the coronary artery, the myocardium evolves through various stages and degrees of severity of impairment. So this is a picture of the zone of infarction. As you can see, it goes to the center core of muscle. The damage has been done all the way through the heart muscle, and it can be reflected. You will start to see Q waves in these patients. If they have Q waves, though, this is the reason why your physician asked to see an old EKG. Because if they've had Q waves in the past, that is probably this thing that's happening currently may indeed be old, because Q waves can either indicate a brand new heart attack or it can indicate a old heart attack as well. So they want to look at that EKG to compare. Were those Q waves there the last time they were here? And if they are, then this is probably not a new event for them. So for my visual learners, I put all three, the zone of ischemia, the zone of injury, the zone of infarction, side by side. So as you see, ischemia, injury, infarction. So try and keep that, memorize that in your head, you know, what order it happens in. Ischemia is your outermost damage, but it's reversible. Injury's the next level, and it is reversible. Infarction, it's damage to an area of the heart all the way through, and it is not reversible at this point. The damage is permanent. Infarct equals death. So this question is a little more complex. It talks about the normal cardiac cycle. You know, that's the stem in this question. They want to know normal cardiac cycle. So when we look at it, the most appropriate answer in this case is B. Metabolism in the heart is decreased during diastole. The diastolic phase is the longest phase. It is 2/3 of the cardiac cycle. So what happens to the heart during diastole? The heart is at rest. So if you had an increase in cardiac output, this would decrease diastole because more time is necessary to eject contents. So your systole is longer, your diastole is a little bit shorter. Cardiac output equals, just a reminder and refresher because you'll probably see a lot of questions about cardiac output. It's your stroke volume times your heart rate. So we're going to talk about why D is not an appropriate answer on the next slide. So the question asks, or choice D tells you that the aortic and the mitral valves are opened at the same point. This should never happen in a normal cardiac cycle. I'm not going to say that that does not occur in some patients, but it should never occur in a normal cardiac cycle. The mitral valve and the aortic valve are on the left side of the heart. They are on the same side. So let's think about, several things. First of all, two valves on the same side should never open at the same time. When we look at diastole, this is when the ventricles are filling, your heart is at rest, and it's the longest phase because, this is supporting perfusion for your body. Coronary arteries, at this point, they're getting perfused. Before contents are ejected, the ventricles are filled. And it's kind of important for you to know for this test and in real life scenarios as well, which valves are attached to what. Your AV valves, which are appropriately named atrioventricular valves, are situated between your atria and your ventricles. So your top chamber and your bottom chambers. These are the mitral valve on the left and the tricuspid valve on the right. And then you have your semilunar valves, the aortic and pulmonic valves. I like to look at these as the exit doors for the heart. The pulmonic valve connects the right ventricle and the pulmonary artery, whereas the aortic valve connects the left ventricle and the aorta. So systole is when contents of the ventricles are ejected. So you can see which valves on this picture are opened during which phase. So during diastole, your mitral valve and your tricuspid valves are open so that the ventricles can fill and perfuse your coronary arteries. And during systole, your pulmonic valve and your aortic valve are open, or your exit doors, so the contents of the ventricle can exit. Oh my. First you talk about pulse pressure, and now you're talking about mean arterial pressure. What's next? Well, it's kind of good to talk about these two because I think that you guys all look at the mean arterial pressure, maybe not so the pulse pressure, but I know that people look at the mean arterial pressure. It pretty much usually is automatically calculated on the monitor. But for this exam, you're not going to have a monitor. So the calculation for your mean arterial pressure is 2 times your diastolic pressure plus your systolic blood pressure divided by 3. So you take all that into account, and the answer is 81. So this may be an easy question for some, and some it may require some thought. It's another question that involves a little bit of math. It's not very complex math, but it's math nonetheless. What they're asking for is what is the cardiac output? So your cardiac output equals heart rate times stroke volume. So that would be 78 times 60 in this case. So the answer is B, 4.68 liters per minute. So what's a normal cardiac output? Well, a normal cardiac output is 4 to 8. And when we talk about cardiac index, what is a cardiac index reference to a cardiac output? So basically, a cardiac index is tailored to the individual. Whereas cardiac output is just heart rate times stroke volume. Cardiac index is heart rate, stroke volume based on body surface area. So it's more specific to the individual. Because if you have somebody who is 6'4", well, they're going to have maybe a cardiac output of 6. So let's say you have somebody 5'4", they're going to have a cardiac output of 5. Is that sufficient? Is it not? Because somebody who is 6'4" is probably going to need more perfusion than somebody who is shorter than that. So cardiac index is basically just tailored to the patient. So I'm going to put this out here. I have to tell you, I had to look up what some of these were. I mean, I knew what Prinzmetal's angina was, but not really, I could have kind of guessed because I was a band person what the crescendo syndrome meant, but Ludwig's angina, I was like, oh. So the Prinzmetal's angina is angina triggered by exertion or emotional stress. Usually it occurs at rest. It usually occurs between the hours of midnight and early morning. Pain is usually severe with these patients. It can be relieved by angina medications, but this is usually an uncommon occurrence. It only occurs in about 2% of angina cases. And this is usually due to vasospasm of the coronary artery. They could, it could be a cocaine thing or something like that. So crescendo angina is also known as unstable angina. It occurs at rest. It's usually severe. It's usually new in onset, but it occurs in a crescendo pattern. So it's pretty severe. Then it becomes more severe and more severe. Or it lasts 5 minutes. The next time it lasts 15 minutes. And then it lasts 4 hours. It's prolonged. Or it starts happening more frequently than before. It crescendos. It increases. So, it was only happening 4 of 24 hours in a day, and the next day it happens 12 of 24, and so forth. Ludwig's angina actually has nothing to do with chest pain at all. It is a nasty looking cellulitis of the floor of the mouth. Their chin's all big and red and cellulitis out. And then Wellens syndrome is specific to the LAD. So in the question they mentioned angina and LAD, so the answer is B, Wellens syndrome. I bet right about now you're ready to throw a dart between my eyes. You're tired of hearing about stroke volume, but you may see questions revolving around this on the exam. Stroke volume is usually talked about in terms of contractility, preload, and afterload. Those three, they go hand in hand. They all play roles with each other. When we talk about stroke volume, we're talking about the amount of blood ejected by the left ventricle with each contraction. Viscosity, blood volume, and impedance are usually components of afterload. The myocardium is sensitive to changes, especially increased afterload. With only minute changes in afterload, the stroke volume can fall significantly. Oh my, I work on 5 Central. We never do CVPs. Or, oh my, I work on 4 West and we don't really do them that often at all either. So hopefully through these PowerPoint presentations I can help you understand CVP waveforms and all that just a little bit better. So the answer in this scenario is D, increased right atrial pressure from closure of the tricuspid valve. So this is a big fandangled looking waveform. I'm sure you're like, oh my gosh, I'm never going to pass this test. Look at this. This is ridiculous. Okay, so there's 100 questions that are going to be graded. They're not all going to be about a CVP. There is some wiggle room for some serious error there. But hopefully, if you review these PowerPoints and things, I will help you understand CVPs a little bit better, or at least the waveforms. So we look at a CVP waveform, there's 3 peak waves. There's the A, C, and D peak waves. There are 2 descent waves, the X and Y. The A wave represents atrial contraction, and it reflects your right ventricular filling at the end of diastole. It usually follows the P wave on the EKG. Your C wave represents right ventricular contraction, and it occurs early in systole. That kind of makes sense, right? After the QRS, it's usually after the QRS on the EKG. So next is your X descent wave. It represents atrial pressure continuing to decline due to atrial relaxation. It's usually a mid-systolic event. it represents systolic collapse in atrial pressure. So, we're closing valves, we're opening valves, that stuff. So then your next peak wave is your V wave, and it's the last atrial pressure increase. It's caused by filling of the atrium with blood from the vena cava, and it occurs late in systole with the tricuspid still closed. So it occurs just before your T wave it occurs just after your T wave on the EKG. After the T wave. So your Y descent, it's a decrease in the atrial pressure. As the decrease in pressure in the atria happens, the tricuspid valve is beginning to open and blood flows from the atrium to the ventricle. This is a diastolic collapse in atrial pressure. How do we actually measure a CVP? Or how does the ACN say we should accurately measure a CVP? You want to look at the high point of your A wave. You want to look at the low point of your A wave. Get your high point, let's say it's 2, and your low point is 1. So 2 plus 1 equals 3. Divide it by 2, it would be 1.5. So your CVP in this case would be 1.5. Your high point of your A wave closely parallels to the right ventricular end diastolic pressure, or otherwise known as maximal filling of the right ventricle. So it is a very good reflection of your CVP. So let's say you have this scenario, and I know this never ever happens in real life. Your patient's in atrial fibrillation, right? Yeah. In that case, because the A wave is a reflection of atrial contraction, you're not going to have an A wave. So what you can do, if you look at this point on here, you can refer to the Z point. The Z point usually coincides with middle to end of the QRS wave. It occurs just before the tricuspid valve closes, and it is a good indicator of right ventricular end diastolic pressure, because it's right when that valve is closing, and all of that pressure is still in there just prior to it being ejected. So you can use that as well. So here are some other tidbits that you could possibly see about CVP. Not to say that I'm done covering CVP. I think I'm done for this PowerPoint though. Other questions you might see: you always measure CVP at end expiration because that is the most accurate representation. Normal CVP is considered 2 to 6. In the critical care setting though, and especially with your septic patients, you want to keep a non-ventilated patient's CVP 8 to 12. If the patient is ventilated, you want to keep it 12 to 15. Because if the patient is on a ventilator, they have increased thoracic pressure, so you should make sure that you're keeping your CVP in line with that. How much pressure goes in the pressure bag is 300. I know a lot of people say, well, I just pump it up till it's green. Well, green equals 300. So this one is another one of those it's kind of straightforward. I mean, a lot of people know about Takotsubo's cardiomyopathy. It's also referred to as broken heart syndrome. It is caused by excessive catecholamine releases. They stun or completely exhaust the midsection and the tip of the heart. So it looks like the patient is having a heart attack or myocardial infarction, but they're not. They'll take these patients to the cath lab and they'll be like, well, they have clean coronaries. It's not only the hot, angry postmenopausal women, it is also the broken-hearted widows that come in with this quite frequently. I've seen this probably a handful of times, and usually it's like an 80-something-year-old little old lady who just lost her spouse of 50 years. Troponin and creatinine kinase levels are usually only slightly elevated. Usually the treatment for this is supportive care and stress relief. I certainly hope you didn't pick B because it said postpartum. So I just want to cue you in. This is one of those, yeah, that's definitely not the right answer, because postpartum refers to we just had a baby. But if you did pick B, I bet you just weren't paying attention and you're just trying to get done with it. So it isn't the end of the world. But I bet next time you have a question like that, you will absolutely get it right. Thanks. Okay, so a few slides ago, I probably shouldn't have said that I was done with CVP questions, because here you go. Here is another one. So the answer to this one is B, increased contractility. Low CVP readings can represent an increase in contractility. Hypovolemic shock from hemorrhage, fluid shift, dehydration, those are also things that can happen with a low CVP. Negative pressure breathing, which occurs when the patient demonstrates retractions, or mechanical negative pressure, which is sometimes used for patients who have like high spinal cord injuries. Okay, and you are done with this first PowerPoint. Congratulations. I want to commend you in your commitment to your profession and to nursing excellence as a whole. I'm super excited that there are so many of you sitting for the Pccn. It's just really remarkable. Again, if there's anything I can do, or you have any suggestions for further PowerPoints, please, feel free to shoot me an email. If you see me in person, tell me. I am more than willing to take your suggestions and run with them. So just holler at me. And also, positive feedback's a good thing too. If you really enjoyed this and felt like you really learned a lot, I'd like to hear that as well. So again, thank you for taking the time to listen to this, and look in the mirror and say, I will pass. I will pass.